everyone so much for joining us today for the End of Life Care webinar. My name is Sarah Fuchs and I am a Community Education Specialist at MDA. We are thrilled to have you here today for the End of Life Care webinar. This is a learning event and it's a part of our larger MDA community education programs, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates and upcoming events. We are recording today's event and we will be posting it to our website for on-demand viewing at a later date. Please know that all phone lines have been muted, but you can still ask questions. We will have a Q&A session at the end of the webinar with today's presenter. Simply use the chat feature to type in your questions. And you can feel free to send in your questions throughout the presentation, but they will be addressed at the end. For over 70 years, MDA has led the way in accelerating research, advancing care, and advocating for the support of our families. MDA's mission is to empower people living with muscular dystrophy, ALS, and related neuromuscular diseases to live longer and more independent lives. Our mission comes to life through 4 pillars, of care through our National Care Center network. MDA care centers across the U.S. support families and individuals from day one of their journey. Champion. Through our advocacy and education efforts, we empower families with information and resources. Catalyst. Through our investments in research, we are furthering advancements in treatment discoveries. And community. Through programs like Summer Camp, our Connections program, and our community events, we are helping individuals and families build supportive connections and relationships. If you haven't done so already, we invite you to join MDA community by registering with us. I am so excited to introduce today's speaker, Dr. Ambereen Mehta. Dr. Mehta is an associate professor of palliative care in the departments of medicine and neurology at the Johns Hopkins School of Medicine. After internal medicine residency and hospice and palliative medicine fellowship, she joined the palliative care faculty at the University of Virginia in 2016 until 2018 and was the medical director of the UVA hospice of the Piedmont Inpatient Hospice Unit. When she joined the palliative care faculty at the University of California, Los Angeles, she initiated the embedded specialty palliative care program in ALS clinic. Since 2020, she has been a part of the palliative care faculty at Johns Hopkins and is the only palliative care expert in the Johns Hopkins Center for ALS Specialty Care. We're thrilled to have you here today, and now I will turn the time over to you, Dr. Mehta.
So thank you so much for inviting me to speak on this topic. I think talking about the end of life can be challenging. It's something that I know we all think about, whether we're ill or not. And from my own personal experience, as well as from studies, we know that people report that having the opportunity to talk about these difficult subjects provides them with hope and peace. And despite them feeling very intimidating and scary, if they're done with care and with skill, the hope is that they are an addition and a positivity in the care of people that we love and people that we take care of, and ensure that people remain in control when so much of these diseases take away our control. It is really important, though, that we do these conversations in small pieces over time with repetition, because people change over time and what you want might change and should reflect what is going on in your life. So I'm grateful that we're able to start conversations here and now. For some people, I'm sure you've been thinking about this, and for others for whom you're just tuning in to see what this crazy talk might be about, my intention is that this talk provides you with practical information that I hope will guide your journey with neuromuscular disease. And it's not going to be a comprehensive review. And I know that everyone who's listening will have their own experiences, their own journeys, their own clinical teams that they're working with. But my hope is that providing some of this information might give you a foundation to explore some of these topics with those people that you love and who are taking care of you and with each other. My clinical experience, as you heard, is specifically working with people who have ALS, and that's only one type of neuromuscular disease. So I will make some references to ALS as examples, but all the information I'm providing today is general information and can be applied to most, if not all, the neuromuscular diseases. I take care of people who are adults. So my focus generally is for people who are in their older ages in adult age range and not so much pediatrics. And so that will not be covered today. Just to start, that I do receive speaking honoraria for the Muscular Dystrophy Association. And so going through our objectives for today, I hope that by the end of this talk, you'll be able to describe how palliative care is different from hospice care, that you'll be aware of the benefits of palliative care and hospice services for neuromuscular diseases, that you'll be able to understand some of the key decisions and considerations that occur leading up to the end of life and in the end of life. And that you'll know where to find some of these resources for supportive services that will, I hope, improve your quality of life now and in the future. So let's start with what palliative care is and why it's different from hospice care. All of palliative care, as you can see in the green, is much more than just hospice care. And most of the people who come to see me in the clinic, as they see my name on their daily agenda, they see palliative care and they know Google search it before or Google search it after. And most of the time it is out there in the world on the internet, really associated with hospice care or end of life care. And my intention usually is to say that yes, that's one part of palliative care, but it's not all of it. The woman who created the field or developed the field, her name was Cicely Saunders. She was made a dame for her contributions to the field of medicine. This quote from her really is the heart and intention and foundation of the field itself. And I hope will kind of be a reminder for you when you're listening to this talk and when you're thinking about palliative care or hospice care, because this is really central to all the work that we do. She says, "You matter because you are you, and you matter to the end of your life. We will do all that we can, not only to help you die peacefully, but also to live until you die." And that's our focus, is really to help people live as well and as long as possible, no matter what. So it's a little hard to describe palliative care to most people. And to be honest, I think even the field of palliative care and other physicians who talk about palliative care, they aren't always sure how to describe it or what it is. I've definitely been referred patients who say, "I don't know why I'm here. I was just told that I need to be here, and my doctor thought it was good for me." And there are some doctors or healthcare teammates who say, it's not time for palliative care, when in fact, really, most people are providing some form of palliative care. It is about improving the quality of life, providing an extra layer for support, and having a team that focuses on patient care. We focus on relief from symptoms, from pain, from stress. It's appropriate at any age and at any stage of a serious illness, and it can be provided along with curative treatment and helps both the patient and their family, their loved ones, their care partners. Many times people worry that you'll hear, is it time for palliative care? Or, "I didn't know they were going into palliative care now." And that's really, I I think a lot of times what people are thinking about is hospice care, which we will talk about a little bit more. But it reminds me that people are don't think of this as much palliative care as much as a they think of it more as a kind of separate part of medicine versus just being alongside the general care of what you're receiving already. And this is partly why. So in the olden days, really maybe as recent as 10 years ago, and even still in some places, um, palliative care was started when when treatments directed at the disease, so neuromuscular disease treatments or cancer directed treatments, were running out or causing problems. And then people would say that, oh, well, we can't do anything more for you. Let's call in palliative care. And then as you can see in the top picture here, so that was, you get diagnosed, you'd go see your neuromuscular physician or cardiologist or any doctor who's leading your primary disease treatment, and they would treat you all this time, and then they would say, oh, well, I don't have any more things I can do for you, or these things are causing you harm, or the person with the disease and their family saying this is becoming too hard for us. Then they say, okay, let's call in palliative care. So palliative care would get called in right here, and it was at the very end of life. And you'd see palliative care for a little bit, and there wasn't a ton that we could modify then. And so then we would transition quickly into hospice care. Nowadays, with more and more literature and education and resources, people are starting to understand that there's good reason to pull in palliative care early on in the diagnosis. And we can find ways actually to help people continue receiving disease-directed care for as long as possible, sometimes even longer than they would have without palliative care, because let's say a treatment is causing side effects and really bad side effects, and the person says, well, I don't want to receive this anymore because I'm miserable and this isn't a good quality of life for me. I want to stop. And so at that point, things might stop, and that might be premature. Sometimes I've seen patients where I can help with those symptoms and encourage them, and we can talk about their goals, and we can help get them back on the path that they actually wanted to be on. And then they continue with their treatments and are able to get a little bit more benefit for longer. Um, and then sometimes that's when we bring in hospice care. And you'll see actually here that in this model, the hospice care is actually longer than in the other model. And that's because sometimes we've seen in the literature and in the studies that have been done, and just from people telling us that, oh, I wish I had been enrolled in hospice sooner, not because they were giving up or they lose hope, but because hospice care, as I said, we'll talk about it further, continues to support people in a way that sometimes traditional medicine or non-palliative care, non-hospice care cannot provide. And so many times hospice care could have been provided for many, many months, but people enroll in hospice and die soon after enrolling. Um, and and that was, a missed opportunity. And hospice care actually also provides bereavement services to patients and families. So care extends beyond just the traditional time that people think of it. Um, it is important then to think about, well, this palliative care sounds great. And I will say that I've been talking about palliative care thus far as a palliative care specialist. I do want to point out that palliative care, as we've talked about, right, it can help people live better and sometimes longer. And it does so as having a palliative care specialist as part of the team. And that is nice because as a specialist, I can focus on dedicated time outside the regular clinical visit. You go to see a neuromuscular specialist, sometimes a multidisciplinary team, and it's a lot of people, it's a long day. And really the focus is on taking care of the necessary components of taking care of that disease. You got to get the testing done, you've got to get the lab work done, you've got to get the medicines taken care of. That all has to happen. And so sometimes just creating a dedicated space and time to process what's going on, the feelings around the uncertainty of living with a neuromuscular disease, for processing loss and grief, for setting goals for your medical care, for improving the communication between the person who's living with the disease, their medical teams, their healthcare teams, their loved ones. Doing all that takes time, and it's nice to have a separated space for that. Sometimes teams have a palliative care specialist as part of the team. For example, I sit as part of the multidisciplinary ALS clinical team at Hopkins, and that's my standard clinical practice. And then sometimes I'll do video visits outside of that so that we can have more time together. Many places do not have a palliative care specialist embedded in the team, but they have a palliative care specialist as part of the system. So they can be referred, just like you would be referred to any consultant or any cardiologist or any kidney doctor, right? And it's just like a separate clinical visit. Many places do not have that, or don't have easy access to that, or those people are kind of pretty filled up, and that is a challenge. And so I think it's important to recognize that there are palliative care specialists like myself, but palliative care is also provided by the medical team, your standard team, your neuromuscular specialist, your social worker, your physical therapist, occupational therapist. They're all doing these things that I'm describing, which is getting to know you, understanding what's important to you, processing what's going on, understanding how it fits in. So I think it's important that there's palliative care is anybody who takes care of anybody, which is all of medicine. And then there's specialists like myself who are able to focus in a little bit more on some of these nuanced components. So when we think about palliative care, then that sounds fabulous to have a specialist who does all this, great. But there are some disadvantages. I would say that you have to think about the fact that you would then have another medical specialist involved in your care. And it's not easy. I recognize how difficult it is, especially towards certain stages of disease where it's difficult to travel, or you have a care partner who has to take time out of their day to bring people to appointments. And you're having to go to see yet another doctor. There's a copay. Palliative care physicians like myself are specialists who are like any other doctor, so we do have copays. And sometimes the available palliative care specialist is a social worker who has expertise or is providing experience. There are many, for example, many ALS clinics who have a social worker who is doing palliative care without a palliative care title, and are just as well equipped to go over goals and conversations with people, and they may not have a copay. So things that are important to think about. And then lastly, like I mentioned, there may not be a palliative care specialist in your area. There just aren't enough palliative care specialists in the nation. And there's also the concern that not everyone understands the value of palliative care just yet. We're working on that as a field, changing to provide more education. But sometimes it's just not feasible. And so those are disadvantages to talking about having a great palliative care person, and then you may not have access to that. So let me switch into thinking a little bit more about hospice then, now that you know what palliative care is and how it is not hospice. So importantly, hospice is not a place to die. You do not have to move out or go anywhere to receive hospice services. It does not hasten death when people are receiving treatments aimed at their disease. They're hoping to live a good life with comfort and safety and dignity. And when these treatments stop helping or become painful or cause too much suffering, then hospice maintains the same goals of achieving comfort, safety, and dignity. They just do it with different medicines and different resources. Their intention is never to hasten death, to give medicines that make people die faster. They allow for a natural process while supporting the patient and their loved ones. And that can be confusing because personally, you may have had a loved one or a family member enroll in hospice and die very soon after. And I hear a lot that people talk about how they enrolled in hospice, they gave them a bunch of morphine, and then they died. And I can't speak to all the hospices out there, but I can tell you that philosophically and intentionally, and the ones that I've worked with, the intention is to provide medications that provide comfort as the sole priority. Sometimes people are really close to the end of life when they enroll in hospice and need a lot more medicines to keep them comfortable. So inadvertently, they receive a lot of medicines and then they are short at the end of life. And so they die soon after. The hope is that they've received comfort in that short time. So I think I want you to hopefully take that away as the intention behind the process and the reality of what we see and how it translates to the practice of care. Again, hospice is a team-oriented approach, and their primary goals are quality of life and comfort for patients and families. So how do they do that? They do it with a hospice team that includes specialized holistic care with a team of interdisciplinary professionals, physicians, nurses, social workers, spiritual care providers, therapists, case managers, volunteers, very similar to a robust palliative care team. They address physical, psychosocial, spiritual, financial suffering for the patient and their loved ones. Most people receive hospice services in their home, where a nurse visits at least once a week, addressing symptoms with medications, teaching and supporting the care partners, and providing the resources that that family needs and that patient needs. The hospice services cover any medical equipment like a bed, a wheelchair, commode, anything that would be needed in the home, and it's delivered to the house. And they also provide medical supplies and medications. Now, the medications are those that are related to the diagnosis for which the person qualified for hospice. That's what's covered by hospice. So, for example, for neuromuscular diseases, if there's medications that are focused on comfort, they will cover that. Sometimes medications are providing comfort and prolonged life as well. For example, if you have diabetes, some people, their diabetes, if the sugar is too high or too low, they get a lot of symptoms. So they will certainly don't want that to happen. So they'll make sure the person's getting insulin or whatever diabetes medicines they need. Many of the medicines for neuromuscular diseases, there's a good chance that many of them will be discontinued for that disease itself. For example, riluzole is a medicine for ALS, and it has been shown to be primarily provided to prolong life. And it's really been only effective for a certain period of time. When people have reached a point where they're being recommended to go to hospice, by definition, it's no longer helping to prolong life because it's reached its maximum point of helpfulness. So because it's no longer effective, hospices will discontinue them. It is important to know that in our country, in the US, Medicare is hospice is a Medicare benefit. So philosophically, hospice should be the right fit for somebody. We shouldn't just recommend somebody for hospice just because it's a benefit, when philosophically it aligns with what the person is wanting, just as I've said. The primary treatments are too painful, or they're no longer receiving benefits, or they just want to focus on comfort, then hospice is appropriate. But I do also think about it as a Medicare benefit, and when can we qualify for it? And so when a disease reaches a point where it seems to the medical team that the prognosis is likely less than 6 months, if it continues as in its natural form, then hospice is considered. And so you can think of it as, how long can I get this benefit from Medicare? At least 6 months. And sometimes people will live longer than 6 months. So if you still meet those hospice criteria at 6 months, the period starts over again. You start as if you were back at zero, and they look to see if people's nutrition and function and cognition are changing in such a way that at this point, now again at 6 months, right? Are we going to live? Could I consider that this person might live for another 6 months or less if the disease continued the way it has been for the last 6 months, or for the last period, or the last period of time? So generally people don't get kicked out of hospice, but there are times where people aren't changing as expected, and that's a good thing. That means that their disease is stable and they're going to live longer, and we all want that. And so then at that point, hospice will say, it looks like we're not in that stage right now, so let's take a break, and then we can always re-enroll when the time is right. So that's kind of a worry for some people. So kind of think through, what are the benefits of hospice? So hospice is a shift in the plan of care. The intention is that it continues to support hope. Sometimes it's a change in what we're hoping for. Maybe the only goal prior to this was we're hoping to live as long as possible. And sometimes that is slightly shifted, where we're hoping to live as long as possible, but also as comfortably as possible. The fundamentals I've seen for most people remain the same. You hope for yourself and for your loved ones to have comfort, safety, and dignity, and that's what hospice wants to focus on. It does this by discontinuing medicines that have side effects or are just relieving someone from having to take so many medications. It can be a burden to take so many medicines, or to discontinue blood work or testing that are uncomfortable, or take a lot of effort to get done. If it's a lot of traveling to go get blood work and it's just not feasible to get in the car anymore, it may be not worth it any longer. By having the healthcare team come home as a reference and to troubleshoot, for care partners and loved ones to feel more support, and then can minimize unwanted ER visits or clinical visits. They provide respite for brief periods of time for the family or for care partners. And lastly, they provide bereavement services for loved ones up to 13 months after the person has died. This may be really helpful for the person who has the disease to know that their loved one has a safety network, so that they know that there's a lot of grief and a lot of preemptive grief and planning as diseases change. And as you're seeing those changes, many people are worried about what will happen to my loved one, and knowing that there's going to be a team to take care of them afterward can be a relief. So there are services that are not covered by hospice because Medicare does not cover them. And because Medicare covers hospice, the rules generally are the same for every hospice in this country. As I mentioned, medications that are solely aimed at prolonging life. In ALS, those would be things like Radicava, Riluzole, Relyvrio. Those would be discontinued. If, for example, you have a 3-month supply of Riluzole that you have filled and you're enrolling in hospice, they will not stop you from taking them. You can take them. If you have a second insurance and and you would like to continue taking the medicines and the second insurance will cover it, they won't stop you from taking it. They won't cover lab work. If there's any lab work that has to be done with medications in order to safely continue it, hospice won't do that either. So you'll have to do that yourself. If you already have a feeding tube at the time of hospice admission, the nutrition can continue, but once the body is no longer able to tolerate these feedings, they will discontinue them to prevent uncomfortable side effects from excess nutrition. Those things are things like sometimes it's a lot of volume of food or fluid, and people get very that backs up into the lungs. It makes it hard to breathe, or it can make a lot of secretions and gurgling sounds, or you can get really swollen. That just happens as our bodies are unable to utilize nutrition as we get to closer to the end of life. And that's a natural process that happens with every disease. So there's a point at which nutrition stops for every disease. If you have a CPAP or a BiPAP, those machines to help you breathe, also called non-invasive ventilation, some hospice agencies may not be familiar with how to handle these machines for people who have neuromuscular diseases. You should have your neuromuscular disease healthcare team explain the management of these machines to the hospice team, so that they don't just discontinue the machine without confirming that it's part of the goals of care. I mean, if they're uncomfortable and we're tired of them and we don't want the mask anymore, the oxygen, that is totally okay to discontinue them, and they will replace the feeling of discomfort from shortness of breath that the BiPAP and the CPAP were providing. They will cover those with medicines instead to make sure that you don't feel short of breath. But sometimes hospice agencies aren't familiar with the fact that these machines provide comfort, and yes, they prolong life. They are a form of life support. And so some hospice agencies just stop them because for other diseases, they're not a source of comfort. For other diseases that are more common, they're a source of discomfort and they only prolong life. But for neuromuscular diseases, sometimes they do provide quite a bit of comfort, and we don't want them just stopping it without understanding. So sometimes hospice agencies will need to contract with respiratory companies to make sure they manage them correctly. For example, there's a machine called the Trilogy machine, and you don't want to end up with a surprise bill for you as a family member. So you need to make sure that those are discussed. Similarly, for people who have, these are called non-invasive ventilation. There are people who are on ventilation, invasive ventilation, or tracheostomies, or who have tracheostomies with a ventilator machine. When you're enrolling in hospice, it is the same philosophy of care. You want to make sure that that is a life support, and it's also providing comfort. So it is the same discussion that needs to be had for people who are on those devices with your hospice agencies, to make sure that they know that those are going to provide comfort. There's a certain point at which they're no longer providing comfort and a family and patient want to discontinue them, or they're no longer providing the benefit, then it's discontinued, but with a conversation about the goals of those care. So similar as the non-invasive ventilation, it needs to be a discussion with the hospice agency. And sometimes you might enroll in a hospice agency that, or you might find a hospice agency that you really like, and then you talk to them about this and they don't know how to handle it. Then I usually recommend either training, if you're healthcare. Many neuromuscular multidisciplinary teams do this. It's just that you might have found you might be from an area that's new or unique. And so that one hospice agency doesn't know how to deal with it, but your medical team should know how to talk with them about it. You just want to make sure that it happens first before you enroll. And then rehabilitation services. So PT, like heavy PT/OT. So if you're going to physical therapy in a facility outside of at home, they won't be covered. They will have to stop coming, or you'll have to stop going. Surgeries, equipment, complex equipment will not be covered. So for example, power wheelchairs, swallow studies, eye gaze machines, those I recommend pursuing before hospice so you can get them and then you can keep them while you're in hospice. They don't take them away. It's just that they won't cover them. So if you've switched into hospice, and you no longer can come to the clinic, for example, then it's very hard to get those things. So I ironically, as I was saying, we want to enroll in hospice sooner than later, but ironically, I often say to people, let's just wait until we get most of the equipment that we need first, especially if it's kind of soon and we're coming up to it. And then clinical trials will not be covered under hospice. So, and many times people by that point are not candidates for clinical trials. So if that's very important to you, then I would wait until you've explored all those things. All right. So we're going to do some myths or truths. And some of these things we've already talked about, some of these things we may not have yet. And we'll go through each one. I think Sarah and the team are going to help us do a little bit of a quiz. Looks like they might have already posted it and people will have answered. But I want to ask if you all will take maybe just a few minutes. I see we've got a 5-minute timeline. If we get most of the answers in before that, we'll just take a look together and see what people are saying and go through them together.
Thank you, Dr. Mehta. I am keeping an eye on this poll. It looks like we've got some answers coming in pretty quickly. So we'll give everyone just a minute to get that done.
You guys are doing great. These are coming in quick. Sarah, was my polling screen up? Could you see that and the answers when I moved it?
Nope, I could not see that on your screen.
Okay, okay. But if people saw them, then let me put them together.
We are not giving away any answers yet.
Okay, all right. Looks like they're coming in fast.
Yeah, we might just give it one more minute and cut this a little early, just to make sure you can get back to your presentation.
Yeah.
I'll wait just maybe 30 more seconds. Thank you to everyone who participated.
Yeah.
Alrighty, I'm going to go ahead and close this just so you can move forward.
Okay.
I will share the results with the attendees.
Okay, great. So let's go through some of them. All right, so first, myth or truth, all treatments stop with palliative care. And I think as we've talked about, and most people were spot on, they said that nope, this is a myth. And that is true. It is a myth. We do not stop treatments with palliative care, meaning that we will continue. It just continues like every other intervention and every other, you can be on clinical trials, you can be on, you can have surgeries, you can have all the regular standard treatment. Nothing has to stop unless in the conversations that people have together with their palliative care team, they decide that those aren't the right things for them or aren't in line with their goals at that time. And generally, what people want and how they want to continue with things really depends on where they are in that moment of time. And the benefit of having conversations that are ongoing allows for that flexibility of decision making that we really want to have, because we want the decisions to reflect your in the moment decisions or in the moment quality of life. Okay. So the next question, patients continue seeing their neuromuscular disease team if they're seeing palliative care. And I think most people, as we talked about, said, yep, that's true. And that is true, that it's just another consultant and you don't have to switch and you don't have to stop. When you are seeing a hospice team, that is something that they are, it depends for some people. So you can still see your neuromuscular team while you're in hospice. There's many reasons that people decide to stop. Some of that is because the travel is too far, or they're not well enough. Sometimes they will have their neuromuscular disease under hospice. You have a hospice doctor who's on call 24 hours a day, 7 days a week, so that if there's any medicine changes that are needed, they are available. Sometimes the neuromuscular disease specialist may not be able to be your doctor for the hospice because they may not have 24-hour a day, 7-day a week on-call ability. In that case, the hospice doctor, the hospice itself has a doctor who takes over that role. And you can have your neuromuscular disease doctor continue and be like a secondary doctor, but they're not the primary hospice doctor. So you can continue coming to see your neuromuscular team. You don't have to stop, especially if that doctor is going to be kind of the second doctor for the hospice. Let's say you wanted your primary care doctor to be your second doctor or your primary doctor, then generally people keep that doctor and the Medicare doesn't cover the neuromuscular disease team. So it's not to dissuade you, it's kind of who you feel the most comfortable with and what are the feasibility options for who can be on call, things like that. All right, the third question, patients cannot continue neuromuscular disease treatments with palliative care. That is kind of similar, but what I'm specifically referring to is the neuromuscular disease treatments themselves. And those, it's a little bit of a kind of re-emphasis of the same point that those neuromuscular disease treatments, for example, the Riluzole with ALS, those continue with palliative care, but they do not continue with hospice care. So just kind of driving home that point. Patients are kicked out after 6 months in hospice. I alluded to this, that patients are not kicked out of hospice at 6 months just because they hit 6 months. And that in hospice care, they're looking for progression or change or kind of problems with the treatments that are ongoing. So that's just something to that they would talk to people about, to you, to your loved ones. They would discuss that before any changes are made, and they should help to find if for whatever reason hospice isn't the right resource at that time, and you do have to switch out. then they should help to find a replacement team, like get you back with your primary team. Okay, patients do not continue neuromuscular disease medications in hospice. And I talked about that a little earlier. So yes, that is a truth. They do not continue neuromuscular disease medications in hospice in general, just because those are primarily focused on prolonging life. If they are aimed at comfort as well, then they would be continued. So it depends on how much they do of both and how expensive they are, of course, in our medical system, and how much monitoring they need. So if there's a lot of labs, like I mentioned, a lot of labs, a lot of follow-up, then they would talk about discontinuing them. We did not go over this in detail, and let's see.
It looks like the questions may have reordered themselves a little bit, Dr. Mehta. It looks like that one's question 8.
Thank you. So the patient must change their code status to do not resuscitate to enroll in hospice. And in a couple of slides, we'll talk a little bit more about that, but people were not sure or didn't, there was a little bit more mix on this. And that's because it's a little bit of so the shortest answer is you are not required to change your code status to do not resuscitate to enroll in hospice. That is not a requirement from Medicare. Where this gets confusing is that if you're going home with hospice, then you absolutely should not be asked to change your code status. Now, understandably, if you're in the end of life or as you're getting sicker and you have more symptoms, the hospice team is going to come to the house and try to address those with their medicines. Let's say that the symptoms are more because you are in the last phases of life and you really are dying. If you needed to be resuscitated, the hospice agency would say, well, you are full code, or, you're okay with getting CPR, you're okay with being intubated, if you already are not on a ventilator, and intubation means being on a ventilator, they'll send you to the hospital. So if going to the hospital is not okay, then that is what the do not resuscitate component of it is. But I've had many patients who are enrolled with hospice services who aren't ready to change their code status for many reasons, and they're okay to go home with hospice. If you're going to a facility, whether that's a nursing facility with hospice or an inpatient hospice facility, they will ask you because you're not at your own house. They are responsible for you. And so they will ask you to change your code status to do not resuscitate. That's primarily for the inpatient hospice facilities, in case anybody's heard of that or been talked about that. That's a separate higher level of care where you go to a facility owned by a hospice where they have to address complicated symptoms. It's different than a nursing facility. Some nursing facilities won't be comfortable with having people in hospice with a full code because they feel that they'll just come to the facility. If they look uncomfortable at all, their oxygen levels drop, they're, having high heart rates, their automatic default is to send somebody to the ER. And if they just came from the ER or they're trying to avoid that, then that's kind of counteractive. So that's where that comes from. So hopefully that's helpful. And then I think all patients are moved into a hospice when they enroll. So we didn't talk about this exactly, but when you enroll in hospice, you do not need to move anywhere. The hospice itself does not require that. It's only if if it's better for safety and comfort and dignity, that somebody needs a facility, that a facility would be discussed. But it's not just because of being enrolled in hospice. And I think that's important because many of the times people enroll in hospice because they want to be in their home at the end of their life. And that's what hospice wants too. So they want to encourage that and facilitate that. If the problem is that in hospice, our insurance, our hospice benefit does not provide 24-hour caregiving for patients or families in their uh, as part of hospice. There's no caregiving services that way. They'll have an aide come out maybe 2 to 3 times a week for about 30 to 45 minutes to help with bathing and dressing and changing, but they don't have 24-hour caregiving, and that falls on family, friends, neighbors, loved ones, hired out-of-pocket care partners, which sometimes people can't afford, many people cannot. And so for families who don't have that option, moving into a place to live, a facility to live, provides comfort and safety and dignity more than what could be done at home, even though it's heartbreaking. And I wish it were different. And we're working on that again as a field. And as if you have a problem with it, please write to the senator in your state. I would highly encourage that. It's the only way to bring attention to the need for more caregiving services. And I know the MDA has a lot of resources for that too, to encourage that. So there's that. So that's our last truth and myth. And we're going to talk a little bit more about some of the considerations that are a little bit harder to consider at the end of life now that you have a foundation for palliative care and hospice care. So some of these, when we talk about end of life, I mean, many times we're picturing really the last days, weeks, hours, but for some people that extends longer, and we're really thinking about what are the decisions along the way of the course that will need to then be also considered towards the last phases of disease. So as neuromuscular diseases progress, there are common decision points that can be distressing to consider. And it's really important to take the time to think about them for yourself, if you're the person with the disease, for your loved ones. It makes the discussions easier. And ultimately, when you're faced with these questions, then it can make those decisions a little bit easier when it comes to it. Please know that there's really no right or wrong choice. And this is where it really helps to get to know someone as early as diagnosis, so that people like a palliative care or your healthcare team and can begin to understand your values, your goals as a foundation. So when these complicated disease decisions come up, that we can be really more helpful advisors, because not one size does not fit all. Ultimately, the decision is yours, and the healthcare team is really providing guidance and advice that we try to tailor towards to you as an individual, and we only can do that by getting to know you. But we are humbly recognizing that we don't go home with you, we don't live with you, we're not you, we don't know you as intimately as your loved ones. So as we get to know you, it helps us to give you information and guidance that we've learned from other people and from our experiences working with others. But ultimately, it's you and your family and your loved ones who make these decisions. So let's go into each one of these. So tracheostomy or invasive ventilator, we'll start there. That's to help with breathing. As neuromuscular diseases progress, we know that these interventions, this will come up. People start, as I talked about, with non-invasive ventilation when the breathing becomes difficult, when muscles become weak. And the non-invasive ventilations, that's the BiPAP, that's the CPAP, they help a lot with symptoms, and they also help to extend life. Tracheostomies are a procedure. They're where they make the hole in the throat, and it's connected to a tube that connects you to a ventilator. And it's also called invasive ventilation because it's actually going into you, versus non-invasive, which are the masks that sit on your face. We know that these interventions prolong life. People can live with a tracheostomy much longer than they would without, and it's a life support. It does not slow down or reverse the disease itself. So for ALS, for example, we know that it's going to continue at the same progression that it would have naturally. This does not slow it down. It is a really big decision. It significantly changes the quality of life for the person with the disease and for the care partner. And then you need to have at least one or two. And I usually say two because if the first partner gets sick or needs a break, then you need to have a backup person to be available 24 hours a day, 7 days a week, in case there's any malfunction with the tubing or with the machine itself. Speaking may be limited. So most people, this becomes their primary way of breathing. And when you, the only way to speak is to put a cover over it with what's called a speaking valve. And the only way to speak is through that speaking valve, but that closes off the ventilator. So if you cannot breathe through your own, with your own muscles and your own lung, because usually that's what the problem is for people who have neuromuscular disease. When they cannot breathe, um, they cannot breathe on their own, then you cannot speak. So these are things to think about as a person who might be thinking about this decision. This will change your quality of life in terms of speaking, in terms of who you have around you, in terms of your family dynamics, as a care partner, who's going to be there with that person. You might develop progressive weakness as you become more immobile. That's going to happen with the disease regardless, but still. And then generally when they put in a breathing tube, they put in a feeding tube because now you can no longer swallow. So I think it's important because it is a major shift, and this is probably the biggest one in terms of interventions and procedures. If you think through this and you think with your loved one, I don't want a tracheostomy. This is okay for me to forego. When I reach this point, I'm okay without this. Then I think that can be a scary thing to say. It can be a scary thing to ask about. But it's important to know that you would not be just uncomfortable. The worry about having significant shortness of breath or having being left to suffocate is a real one that many of my patients talk to me about, families talk to me about. And you shouldn't feel that just because you don't get this intervention that you're going to be suffering. That this is where medications that we provide for comfort and for breathing and for pain can be very easily provided. And we just make sure that when a person reaches this point that we have those medicines in place. And this is usually a time when, at that time, usually hospice is what we recommend to make sure that nobody is suffering from trouble breathing. Feeding tubes oftentimes are a decision that for some people come before a breathing tube. And it's also called a percutaneous endoscopic gastrostomy. That's a long word. PEG tube is what people will generally say. It's a small little tube that goes through the skin and sits inside. There's like a little balloon. That's what this is, that gets inflated. So it's soft. Once it's in, it tends to be pretty comfortable. There's this thing called an anchor here, and it holds it against the skin for people. So once this is healed, it tends to be pretty much, you forget about it. It's generally a pretty straightforward procedure. It does help people live longer. It improves hydration, minimizes weight loss, and makes medications easier to give. And it decreases the fatigue and the stress around eating by mouth so that it can become, because sometimes my patients will tell me, I can eat, but I'm so stressed out about getting all the calories I need, and I'm just so tired, and they become anxious just from that, feeling this weight of I've got to eat. So sometimes it can be a real relief, and then it brings back the joy and the pleasures of eating. And you don't have to rely on it for all your calories. When is it recommended? It's recommended for most, well, so every disease will be slightly different. I'll give you the example for ALS. Your healthcare team will decide and give you advice on when they'll try to give you preemptive advice for we're seeing that this might be coming up around the corner. You start thinking about it. And it's something where, hopefully you have enough important time for people to think through whether this is a right move for them. I've had patients for whom they're absolutely sure that they do not want a feeding tube. And we've talked about it as early as diagnosis because they were thinking about it. And then as we get closer to the time, maybe their quality of life is okay and they want to reconsider it. And that's important. Sometimes they go as far as getting the consultation and then deciding, nope, this isn't for me. Sometimes, we place it and it's purely for the logistics of medication administration to make that easier because that's important to somebody. So there's a lot of different reasons to get a feeding tube. Generally, it's recommended before somebody's breathing becomes too weak to get a procedure done because you have to be intubated, sedated. It's a procedure done under general anesthesia, usually. And when they do that, they put somebody to sleep and then you want to be able to get the breathing tube out to take them off of that. So we sometimes will recommend it before there's any problems with the breathing to get it done so that we can safely go through that procedure itself. Resuscitation is one that we talk about. That's a difficult topic. It's one that makes people, we see it a lot. This is the most common procedure seen on a television show and most common misconception of what we can and cannot do in medicine. It does not, it's difficult because when people are thinking about this, this is relevant for whether you're ill or you're not. So it's kind of something that's always in the medicine world talked about, but it's a little bit different when people have a neuromuscular disease. And again, it's also different at different phases of the disease and what your quality of life is, and also what your hopes are for what you might be able to do or not do after a procedure like this. This refers solely to when someone's heart has stopped and they need CPR, which includes when you get CPR, that's the chest compressions and shocks. It also includes putting somebody on a ventilator or to be intubated for breathing, because when your heart stops, it doesn't send blood to your brain and doesn't send blood to your lungs. And so you need to put oxygen into there so that you can get that moving. And so the most successful way of doing CPR is usually with some kind of airway support. This decision does not impact any of your other medical decisions or care provided outside of this. So it does not impact whether you get a feeding tube or you're on a ventilator for the ALS itself. I often separate those things out. We talk about being on a ventilator for the neuromuscular disease itself, and then what you'd want to do if if your heart stopped and if you really died naturally and needed CPR. They're separate things. It doesn't impact whether you go to the hospital or not. It doesn't impact whether you get medical treatments or not. So I just want to be very clear about that. And it's not specific, I put up here ALS, but it's not specific to neuromuscular disease. It's for any disease, for anybody, well or not. Every person should consider whether they want this, because in the United States, the default for every person is to receive resuscitation. So if you've not indicated what you would like, then you will be resuscitated. And some people, I recommend that if you know that you do not want that, to write it down, to put it on a bracelet, to have it with you at some point, to tell people that you know, so that it doesn't happen accidentally, because the default is to just go and do it. And depending on how well you are at baseline, how functional you are, how cognitively clear you are, the ability to resuscitate you back to the level that you were before you had this episode can be very significantly different. For young people that we see on the TV who have no illness, this is it is more likely that you'll be able to be resuscitated back to how you were before. But if you start out with a disease or a very sick illness or multiple diseases, or you're older, very rarely are we able to successfully bring back someone to the way they were at that level before the CPR, but it doesn't necessarily mean that we won't be able to bring you back. So it just needs to think about where in between are you okay living, and what would you be willing to accept or not accept. And that will help to guide your loved ones when you are unable to speak for yourself, and it will help to guide your medical team as well. when I say to write it down, this is what you would write it down on, which is called a health, or when I say to talk to somebody and to tell the people that you love, it's a healthcare agent, a power of attorney. This is the person who would speak on your behalf if you cannot make a decision for yourself. This does not apply to financial decisions, it's solely medical. And ideally, this is the person who knows you well enough that they would be able to guess, or even better, know exactly what you would want if you could speak for yourself. It does not need to be a family member. In different states, there would be different surrogates, which are the default. So in Maryland, for example, it goes to a spouse first. So if you haven't designated somebody, first it goes to your spouse. If you are estranged from your spouse, but you're not officially divorced, then it still goes to your spouse. So that's why it's important to write these things down. Then it goes to your adult children, and they all have to agree together. So if you have children who have not spoken or who would not agree for whatever reasons, or don't know you or haven't been with you, but there's one of them who would, and you want them to be your person, again, that would be where you'd write it down. Otherwise, the healthcare team has to find all the children and make sure they all agree. And then it goes to adult parents if they're still living, and then adult siblings all have to also agree. So again, if you have one sibling who knows you better than the others or could handle it, or whatever life situations are going on, I would pick those. So I would write it down. Once you decide, you should let that person know and talk to them about what you would want in certain circumstances. You may not know every medical circumstances. Nobody does. I don't. But if you give them general guidance about what's an acceptable quality of life, what's meaningful to you, they can help then talk with the medical team to help figure out what's right or what's not right. If you write it down, and these are usually notarized or need two witnesses. You don't need to go to an attorney to get this done. You just need to, every state has different paperwork. So I would look at your state and I would look at the paperwork for that. And then the other part of this document up here is what's called an advance directive, or a living will. These are legal documents. They do not need an attorney, again, because this is not financial. This is medical. And this is what includes your healthcare agent power of attorney. So some patients aren't ready to fill out the rest of it. They just only fill out the healthcare power of attorney part, sign it and date it, and that's legal and that's okay. These are usually free, so you can find it on any website for your state. And again, not every state will overlap, so you just want to make sure that you find the one that's relevant to yours. I describe these as formal evening wear. You should take them out once a year and make sure they still fit, or any major event like going to the hospital. You just want to make sure they still are relevant and reflect what's important to you, what's going on in your life, because they're free and they're not easy to do. I fully acknowledge that. They take time, they take effort, they take stress, but it's good to review these regularly and make sure they're still relevant. These are different from POST forms. If you've heard POST forms, POST stands for portable medical orders. That's what they're rebranding them as. They are orders that these are advanced directives are like guides to the medical team. They just kind of generally tell somebody what's okay and what's not okay. But the medical orders form, the MOLST or POST, those are doctor's orders that can only be filled out by a healthcare provider, a doctor, a nurse practitioner, a physician assistant. They're orders that designate, they include things like feeding and dialysis and antibiotics. And so they're very granular, and it's important to go through those as well, filling those out, and then also keeping those on hand, because the EMT folks, they actually follow those. If you give them an advance directive, they can't translate that quickly enough. They can generally know what you want for your code status, but not for these other detailed things. So in the last few slides, I want to just go through what's legacy work, which is really important. Legacy work is a story to preserve, is a way to preserve your story and your values. It's an opportunity to make connections and share precious moments with the people special in your life. And it's also an opportunity to reflect on your life and process who you are while planning for the future. So for many people, it brings deep meaning and healing, can produce something tangible for the people that you love, and to keep that can be passed on for generations. Um, there are many ways to do this. Generally, it's what works for each individual. So examples that people like are, making a scrapbook or creating a video, writing letters to your loved ones, or purchasing gifts. Um, Had patients write poems or songs or create drawings. We'll do things like make fingerprints or handwriting keepsakes. These are really important things that can be meaningful and deeply provide a deep sense of connection for you and for your loved ones as you go through this journey. And so I think it's important that you have some resources for these steps. There are educational resources that are out there. Most of these are free, so I wanted to provide you with, and many of them are ALS because my expertise is ALS, but MDA has a ton of resources that are free, and many of these are actually quite translatable. And so there's a company called rune.com. They do these short little 2-3 minute videos with neurologists and palliative care and spiritual care, financial and legal as well. They're free. There's these other websites for ALS specifically. There are legacy work resources that some of them have fees and some of them are free. So I have these here for you. I know the slides will be out and you can use them. And these are actually provided by social workers in our group, so I think they're quite up to date. And then getting affairs in order. This is a really tough one, but it takes an average of 12 to 13 months to handle the paperwork and affairs after a loved one has died. And many people spend an hour every day to get these tasks completed. And they're really hard to do while you're still actively grieving. So talking and thinking about these things can be really hard, but it can be a really big gift and important thing to your loved ones. So these are free, and these are things that you could peruse through if you feel brave enough to do so. They have a lot of checklists, which is nice, and they have a lot of help with creating legal paperwork and things like that. And they also have a forum for advice from the community and how to help think through advanced directive forms. And then lastly, I'll put in a little bit of a plug. There's an International Neuropalliative Care Society where it's a new starting group. It's really more of an advocacy group trying to empower not healthcare providers. It's got healthcare providers involved, but it's really focused on patients, care partners, trying to get people to be connected as a network and then figure out how to best bring palliative care to the community of of the neurological world. So if you're interested in participating, the website is free. There's a lot of educational things, and becoming a member has a nominal fee for patients and care partners. But it's a really good way to that we're trying to expand the community. So I'm just putting that out there. So in take-home points, I hope that we talk, at the end of this, that learning that palliative care and hospice are separate services, that they're aimed at improving quality of life, and they have multidisciplinary teams, that palliative care can be provided at the same time as life-prolonging interventions. And there's a lot of disease decisions throughout this disease that can extend life, but don't necessarily improve the quality of life, and then they should be discussed. And then there is a lot of resources that I hope that will be helpful to you and to your loved ones as you're going through this. So thank you so much for the time and for being willing to listen to this. And I hope we can have some time to do some questions.
Thank you so much, Dr. Mehta, for that informative presentation. I am going to take it over here so that so we can do some questions and answers. I do have some questions recorded here that some participants have submitted when they registered. So we're going to do our best to get through all of these questions. If we do want to leave a little bit of time at the end just to close out, if we don't, feel free to contact our MDA Resource Center. They are happy to help connect you with resources and connections that can help you answer your questions. So I'm going to start here with what advice do you offer concerning choices that will lower the quality of life as in loss of speech or independence in exchange for a longer life?
That's a really great question, and it is the foundation for having a lot of these discussions. I think the advice I generally have is for a long time, the hope is that all these treatments and everything that we're doing um, it does both, right? Gives you both quality and quantity of life. As you define quality of life, that's going to change over time. What you define as being okay to live with will change. And generally, my advice is, as you take just even asking the question and pausing to say what is important to me, what is not important to me, that can help to restructure um, whether there are certain priorities, because there I recognize that we can't fix everything, and medicines at some point run out of their efficacy and they run out of helpfulness when you do reach a point where you have to pick between quality over quantity. The best advice I can give is there is no right answer, and to listen to your gut, to your advice, to your heart, getting the counsel of the people who know you the best. And sometimes putting a time limit can be helpful too. If you say, I need to get to this, I have a family member who's getting married, or I want to see my son graduate. It's going to be in 3 months. So I will, sacrifice to get to that point. And sometimes that goal is achievable. And sometimes, as we're aiming towards that goal, we might be in May and you want to get to July. And then in June, it's just really not going well. I would highly recommend rethinking and talking to your healthcare team and saying, is there anything that I'm missing? Anything else that we can think of? If not, it's okay to let go and change the goals, be flexible. I think that's really what I want to encourage you to do.
Great, thank you. I did see something in the chat. I just want to remind everyone that this is being recorded. It will be posted on the MDA website, and you will also get an email when it is ready. So you will be able to rewatch. Next question. I would like to understand as a patient how we can handle this tough stage emotionally.
I think some of the ability to think through the emotions is by creating the space to talk about them, and that can be really scary. Being able to just pause and take some time out to say, I'm going to prioritize discussing how I feel today, and finding those people who can do that with you. It really may not be the person who is your day-to-day person, and that's okay. There's no, it's not because that day-to-day person is not doing a good job or you don't trust them. It's sometimes people just need a different person to listen to. Sometimes your healthcare team can be that person because we're a little bit removed. And sometimes we're not that right person. But I would encourage you to bring it up to your healthcare team, because sometimes there's a little bit more that's needed. Maybe it's a therapist or some just a created space that can be done. These are really tough times, and giving yourself the grace and knowledge, and just saying it's okay if I don't feel okay, which is very cliche, I know, but it is very true. Sometimes we power through because we're trying to be strong for the people that we're working with or that are working with us. And it's okay to have really bad days, and that's normal. It's very, very normal to have a lot of bad days, and cherishing the times that you do have good times, maybe taking those moments to reflect, and then looking into maybe some of these legacy work can help with some of that healing as well.
Perfect, I agree. So this next person is looking for suggestions for additions to the standard advanced directive form and talking points with family physicians and facilities.
I think I don't know of many additional, so advanced directives, there are the state advanced directives. There's one called 5 Wishes. If you Google search 5 Wishes, generally that comes up, or 5 Wishes advanced directives. It's not valid in every state, but it's most states. I think it's 40 states. It's a little bit more like a workbook. So there's a little bit more room in there to write in what you would like. There are, as I mentioned, the post forms. And then, so that I hope are helpful additions to the forms themselves. Thank you, Sarah. And then Sarah, what was the second half of that question?
I apologize. Let me bring it back up
Oh,
here.
I'm sorry.
So suggestions for additions to the standard advanced directive form and
Yeah.
talking points with
Oh,
family, physicians, and facilities.
yeah. So talking points. So there are, you know, maybe from the talk today, uh, some of these kind of big decisions, right? The tracheostomy and the feeding tubes and the CPR. Those can be kind of starting points. Symptoms and managing and thinking about kind of quality of life from the perspective of symptoms. That can be sometimes a way of kind of opening up some of that conversation and saying, how do I want to make sure that I'm as comfortable as can be? And then, are there any major goals or major things that you need to uh, kind of achieve or get to or things like that? The MDA has a lot of really nice things on the website, and we're developing more together. So I think that would be helpful. And then I would say rune.com, because I've given a few of these talks, they're kind of bite-sized pieces, so they can help with some of the communication talking points as well.
Great, thank you. Um, let's see here. I've read most people wait longer than needed to get their loved one on hospice care. Who can evaluate for hospice at home?
That's a good question. So first, I would start with your healthcare team because they can help think about when is hospice the right timing. So that, or like when can we get involved? Um, Usually, if you have a team nurse practitioner or social worker or the neuromuscular specialist themselves, and so I would ask them if hospice is the right resource. And then if they say yes, and I would, even if they say no, it's not right now, but we'll put in a referral, they can put in a referral for information purposes only, which is free. And they and then you're not committed to anything. So then generally what can happen is your social worker can give, or the MDA often will have liaisons, or if your institution has an MDA liaison or an ALS Association representative liaison, whatever organization is there, or the social worker, if neither, because some clinics don't have that, then I would ask them for a list of hospice agencies in your area, and then they can put out a referral to some of those, and you can talk to any of them for free. And then they will come out and talk to you at home and talk to you and in that home environment, and then they can assess that way.
Thank you. And I think we're just going to wrap it up with one final question. Um, can you just highlight some of the services that hospice offers to family members?
So indirectly, where they're providing services to the patient, of course, where they, I think even just so there's education, right? They teach about the disease, what to expect, how it's progressing, can talk about prognosis. They can talk about medications and how to use them and when to use them, so that especially if you're, like let's say you have a loved one who wakes up at 2 a.m. with trouble breathing, instead of having to call 911, you call the hospice nurse and they will direct you over the phone. They'll come out at 2 a.m. if it's not working. So there's some of that education, which is helpful. Um, they can, they have resources through support groups to help people uh, uh, make sure that you're not alone in this journey. And then, of course, they have, the equipment and things like that that I spoke about. Um, and then they have a social worker, they have chaplains, and they have care managers to help with logistics of planning things. For example, as you're getting closer, if you have questions about, so if you have spiritual care needs, the social workers and the chaplains, they can provide support for the family. They can sit and talk with the family about those things. If you need questions about, funeral homes or logistics about traveling or getting out of the house, they can help with that. If there's just kind of respite care that's needed, so they can come and give you a break to go out. They have volunteers to do that. They can physically come and help with bathing and dressing and changing. So some of the physical, emotional, and spiritual needs for families are addressed as well.
Great. Well, thank you so much, Dr. Mehta. We sincerely appreciate your time, expertise, and everything you do for the neuromuscular community. I am going to wrap it up here just by talking a little bit more about MDA. If you are new to MDA and have been diagnosed with a neuromuscular disease under MDA's umbrella, or if you are a loved one, excuse me, of someone who is diagnosed, we encourage you to stay engaged with us at MDA. You can do this by visiting mda.org/join and completing a short form. Joining us is free and will keep you up to date on the latest research, educational programs, and supports. We would love to hear your comments about this webinar. Once you leave the webinar, a web page will automatically pop up with a short survey about today's webinar. Completing this survey will provide us with important insights as we plan for future educational programs. If anyone has questions after this webinar, please feel free to email them to mdaengage@mdausa.org, and we will follow up with you. This concludes today's webinar. Thank you again, Dr. Mehta, for your time, and thank you to everyone who attended. We hope to see you again soon.